Right. So we are getting at the back part of chapter 37 now. This lecture is actually going to review some of the information from tracheostomies, just because I want that to be kind of an ongoing conversation when we move it. We didn't touch base on them a lot in the second part, and a a big portion of this module goes over trach care, things like that. So it's important that we understand tracheostomies. Um, and then we'll talk about kind of some of those airway traumas associated with tracheal tubes, some ways to prevent it, and then go into airway maintenance. All right. So again, a tracheotomy is the procedure of establishing access to the trachea via the neck incision. So this is where the surgeon is making an incision in the neck and placing a tracheostomy tube. So typically this procedure is done either surgically or with a percutaneous dilation method. We'll talk a little bit about the advantages and disadvantages of those in a second. The procedure is always going to be performed by like a physician, usually like ear, nose, and throat (ENT) physicians in that surgical setting to try after we've established or stabilized the patient's airway. We tend to try to not do these at the bedside. Um, and the tracheostomy tubes, I've shown you in lab before, but tracheostomy tubes come in many different sizes and shapes. So the tube that you're going to select is going to depend on like the patient's age, height, weight, and their kind of airway anatomy. So your book kind of gave you a really nice um, kind of layout on page 767, which talks about when you should be doing a trach. So tracheotomies are preferred as kind of a primary route of establishing an artificial airway anytime the patient has any sort of upper airway obstruction or trauma. Um, so, but we also will do a tracheotomy when the patient demonstrates that they're going to need long-term ventilatory support. So typically when patients are intubated, they're intubated for about 3 days. If it starts getting longer than those 3 days, then we're going to start looking at potentially tracheing the patient. So if they're in that 7 to 10 day window, they're going to be evaluated daily for the possibility of extubation. If they've failed multiple extubation attempts, or if we're looking at needing to be trached for longer than 21 days, or needing to be intubated for longer than 21 days, then we would really start considering that tracheostomy tube. Okay, so the procedure, some advantages for surgical. See here. We're trying to find the page it's on. Next page, 768. There's a table that goes through this information. So the advantages of the surgical tracheotomy procedure is that it can be done in patients with poor landmarks or abnormal anatomy. It can be done emergently, and it can be done on children younger than 12 years of age. Percutaneous trachs, this is done a lot of times at the bedside in the ICU, which is an advantage because you don't have the risks with transferring patients. The sedation is usually a lot less. It's just usually local anesthetic and sedation medication. And the size of the stoma is usually smaller, so it stabilizes much quicker. So the disadvantages are kind of the opposite. patient has to be transferred to the OR for the surgical ones. They require that general anesthesia. And usually that stoma takes a little bit longer to stabilize. Percutaneous trachs we cannot do on children less than 12 years of age, and it sometimes can be difficult if there's certain airway anomalies that make it hard to get through those cartilaginous rings. All right. So back to just kind of explaining the parts of tracheostomies. You're going to have a flange, which is this outer portion here that holds the trach in place, and it allows for trach ties to be attached. On that flange, as we demonstrated in the lab a couple weeks ago, you can see the markings on it tell you outer, inner diametal, or specifics about what type of trach it is. So there's the shaft, or the outer cannula, is the portion that's kind of the outside of the tracheostomy tube that sits within that tracheal wall. There's the inner cannula that's removable and interchangeable to help, treat or prevent airway obstructions and infections. I missed the 15mm universal adapter there, so you can hook it up to your ventilator or manual resuscitator. You have your cuff that needs to be inflated for mechanical ventilation, and that's attached to this pilot line and pilot balloon. And then we have an obturator. This helps with insertion. So I showed you a bunch of different varieties of trachs a few weeks ago in lab, and it's just important to remember that the sizing of each of these varieties of trachs are going to be different. So Jackson and Shiley, Cortex, Bona, all of those sizing doesn't match up with each other. So Portex, Bavona sizes of the trach are equal to the inner diameter of the trach tube, just like on an ET tube. But Jackson, Shiley sizes they kind of make them up a little bit. That's not exactly, a size 6 Shiley is not the inner, 6 is not the inner or outer diameter of that trach, which is frustrating. So therefore, those size 6 Shiley is not going to necessarily equal a size 6 Portex. They're not interchangeable. So when you're looking at replacing trachs, you need to kind of look at a comparison chart or compare the outer diameters of each of the trach tubes to make sure that the size of the trach inside the airway is the same. So it matters more the outer diameter of the tracheostomy tube than the inner diameter. So in general, Shileys are typically larger. So like a 4 Shiley is going to be equivalent to a 6 Portex. And then I talked about in lab how they can come cuffed, cuffless, or uncuffed, fenestrated. So that means there's that little hole in the top of the outer cannula. These can be cuffed or uncuffed. You can have extra long proximal or distal, so where the extra length is. They have special foam cuffs, trachs, that we're going to talk about in a little bit. Tight shaft, water-filled trachs that, again, serve certain purposes with preventing or in your patients that have existing airway trauma. Trachs that have adjustable flanges, and then metal trachs. So kind of gave you some pictures of all of these different types of tracheostomy tubes. So extra long proximal means this length, this horizontal length from where the trach enters the patient's tracheostomy tube enters the patient's trachea, and where that curve starts. So this length is longer here. Distal extra length, the length is longer this way. Watered filled, tight to shaft, looks like this. That just is a different way that we're, using pressure in those cuffs to seal that airway. Here's your fenestrations, cuffed and uncuffed. Here's your Jackson metal trachs. Here's a Bavona trach, which has this adjustable flange. So this tracheostomy tube is kind of has a metal coil in it. So you see how it looks straight right here, but it's got kind of a metal spring coiled around in it. And then the doctor can push more of the trach in. So this outer distance is going to be shorter, or they can lengthen it depending on where they want that tracheostomy tube to fit in the patient's trachea. So those are kind of interesting. All right, so moving on, laryngeal lesions. So some of these things we talked about, I'm not going to go back through laryngectomies because that's not as pertinent to this module, but you can have trauma associated with tracheal tubes. So those artificial airways that we put in, because they don't conform exactly to the patient's airway, it can cause pressure on certain parts of that soft tissue in the airway, and that pressure then will result in things like ischemia, or which is that blocking of the blood flow, or ulcerations where the skin actually starts breaking down. So the most common types of injuries to the larynx are going to be your glottic edema, your vocal cord inflammation. Those things are going to be the most common. They're kind of self-resolving. They don't usually take very long for that to kind of fix themselves. But for patients who have been intubated longer, they might end up with ulcerations or polyps, or even vocal cord paralysis and stenosis. So when we're looking at ways to diagnose this damage, first and foremost, physical exam is really important. We want to make sure we are doing a thorough physical exam on our patients anytime we're considering extubation, and then following up after extubation. We want to be monitoring our patients closely to make sure that we're catching any of this presence of an airway edema fairly quickly, so that we can, treat it and hopefully not have to re-intubate. Air tomography is kind of using CT scans to look for air trapped in the patient's airway. So different, looking at the airways, like with the CT scanner. Fluoroscopy is kind of like a moving x-ray. This, a lot of times we do, if we're looking at swallow studies, we're looking for fistulas, things like that. They might do a fluoroscopy with contrast to see if that contrast, as after the patient swallows it, ends up where it's not supposed to end up. Laryngoscopy or bronchoscopy, where we're just looking down the patient's airway to look for any types of trauma or alterations. MRIs and pulmonary function tests can also be done. All right. So, like I said, the most common laryngeal injuries associated with intubation, and again, your endotracheal tubes are what's going to cause these laryngeal lesions, because tracheostomy tubes sit below the larynx. So you shouldn't have laryngeal trauma when your patient is trached, but can happen when your patient has an endotracheal tube. So again, that's going to be your glottic edema is going to be the most common. Vocal cord inflammation, those laryngeal or vocal cord ulcerations, and those vocal cord polyps and granulomas. All of those are can be kind of common. I would say glottic edema and that vocal cord inflammation are going to be the most common. Less common is that vocal cord paralysis or laryngeal stenosis. So that glottic edema and inflammation, that usually is caught as a result of pressure from the endotracheal tube or trauma during intubation. So typically we want to watch our patients for 24 hours after extubation, assess our patients before we extubate to see if there's any presence of this. Um, because that swelling can kind of continue within that first 24 hours. So the primary symptoms that we're going to see is evidence of hoarseness or stridor. Um, that hoarseness, a lot of times, most every patient after you extubate them is going to sound a little hoarse at first. That usually resolves fairly quickly on its own without treatment, but stridor can be a little bit more significant or serious. Stridor is that high pitched wheezing noise that comes from during inspiration, and this can be a sign of upper airway obstruction. So if you are hearing stridor, then you probably are going to want to try to treat it. Typically, we're going to treat it first with like racemic epinephrine. You can add a steroid to that to help reduce the inflammation. So some steroids would be your Pulmicort. Those don't work very quick, so typically we just stick with the racemic. But if we think that we're going to have this laryngeal edema, like we predict it because the patient's been intubated for a really long time or they failed previous extubations, then we would probably want to pre-treat the patient by giving them IV steroids or diuretics prior to extubation. So the epinephrine, if you remember, epinephrine, racemic epinephrine, all of those medications, those act as vasoconstrictors. So those are going to constrict that vasculature in the airways and reduce the swelling. Steroids reduce inflammation and diuretics reduce fluid. So all of those can help with edema. So you're going to suspect potentially that the patient might be experiencing some vocal cord paralysis if the stridor or hoarseness isn't resolving with treatment in time. So most of the time, patients' symptoms are going to go away within 24 hours. So if those symptoms are not going away, then we would suspect that there's probably vocal cord paralysis. To diagnose this, they typically go down with a bronchoscope and observe the vocal cords for movement. So they'll take the bronchoscope, look down the patient's airway, and look to see that both of the vocal cords are moving. So vocal cord paralysis can happen. So if you think about your airway, this is your trachea, right? And when we look down into our trachea, we see our vocal folds. So this is tissue here, this is tissue here, and then this here is my glottic opening. All right, so typically they're going to be adducted or open during inspiration. And then they're going to, or supposed to close during like certain types of maneuvers, like the Valsalva maneuver will close your vocal cords. Your vocal cords should be moving as you're talking. So when you swallow, your vocal cords are supposed to close. So if you have vocal cord paralysis, you can have one side here end up being paralyzed in the closed position, which obviously then restricts my airflow here. I can have both sides closed in a semi-closed position, restricting my airflow there too. So one side or both sides can both be paralyzed, and this can cause partial or complete or more severe airway obstruction. And we typically see that with bronchoscopy. So tracheal lesions then. So tracheal lesions can happen with endotracheal tubes, prolonged endotracheal intubation, or with or any other type of tracheal airway, like a tracheostomy tube. So you can have granulomas, which are kind of these kind of weird scar type tissue or fibrotic type tissues in your airways. Tracheomalacia and tracheal stenosis are kind of the more common ones. Less common, but more severe, would be your tracheoesophageal or your tracheoinnominate artery fistulas. Okay, so tracheomalacia and tracheal stenosis can occur separately or together. So stenosis, or here, let me move on here. So tracheomalacia is kind of that softening of those cartilaginous ringings in your airway and can cause like a collapse of the trachea during inspiration and expiration. There's also some types of an anatomical issues patients can have that can cause this to be more likely. So I'm just going to play this video for you. I think you did a nice job
Tracheomalacia
discussing it.
describes the collapsibility of an airway. It's a complicated disease and is
That's not good.
tracheomalacia describes
There we go.
the collapsibility of an airway. It's a complicated disease and is often misdiagnosed because it's felt to be so uncommon that when you have noisy breathing, they'll be thinking of something else like croup or asthma, rather than thinking of airway collapse or tracheomalacia as part of the problem. Tracheomalacia can cause noisy breathing, so a very loud cough, recurrent infections, and even worse, recurrent pneumonias that cause damage to the lungs and the airways. Right here's my breastbone, and behind that, all the way in the back, is my spine. And in here are different structures. In general, there's the esophagus, then the trachea, then the blood vessels, and then a thymus gland, and then the sternum. So you have a little sandwich. And if that space is too narrow, something's got to give. The trachea is only going to squish so much. How do you get more room out of that sandwich? That is the essence of treating tracheomalacia. Tracheomalacia really comes in three very broad categories. The most common type that we see is when you have normal cartilages, but instead of being a C shape, you have a U-shaped or even a bow-shaped cartilages. Now they're just as strong, but the membrane on the back is very flexible. So when you exhale, that membrane goes up and touches the front of the cartilages and collapses all the way in. That's the easiest type to treat, and fortunately the most common type. The second most common type is where things are shifted slightly, and instead the blood vessel on top, say the innominate artery, has been leaning on it. Now you have an airway that's considerably smaller while you're breathing in, and when you breathe out, it gets even more narrow. The third type, which is less common and more severe, is associated with cardiac disease, where things didn't develop right. Two aortic arches, one on either side of the trachea, squish it, so it's now half or a third the size. Or you have an abnormal blood vessel squishing it from the back. Boston Children's is the perfect place for innovation in this field. Our familiarity with that fine detailed anatomy in these babies really allows us to become innovative when we have a challenge that nobody else has been able to solve. In the next video, I'll talk about treatment options for each of these types of tracheomalacia.
All right, so that was kind of a nice bit. I just like the graphics he used. So he obviously was talking about a bunch of different types of tracheal malasias that don't happen directly from prolonged endotracheal intubation. But I thought the visuals are really good. Kind of the um, same things are happening with these congenital ones that he was talking about versus the ones from trauma. but usually the ones from tracheal trauma are on the anterior portion of the tracheal wall, and that cartilage gets kind of floppy. So tracheal stenosis is a narrowing of the lumen of the trachea, um, from kind of fibrotic scarring. So here in this picture that I found over here, you kind of see a normal trachea, and then next to it, like a 0 to 50% obstruction or narrowing stenosis. So you see kind of narrowed a little bit. And the next one, you're seeing kind of more and more obstruction building up. And then obviously these last two, you see this airway and this grade 3, where you have like 70 to 99%, you have very little opening. So you think about how much this airway has narrowed, the diameter of this airway has narrowed, which we've hopefully um, talked to you enough about airway resistance now to know that as that diameter of that airway narrows, my airway resistance goes way up. As my airway resistance increases, my work of breathing also increases. It's going to be a lot harder for me to breathe with through that coffee stir or narrow airway than it is for me to breathe through this nice open one. um, so in tracheostomy patients, especially in tracheostomies that don't fit properly in the airway. That's why there's so many different sizes and so many different ways that these trach tubes are shaped and measured. Because if this doesn't fit in the airway properly, that can cause like the cuff to rub up against the wall if I use too much cuff pressure, or the tip of the tube could end up rubbing against the interior walls of the trachea, causing some scarring. And then around that stoma site, or at that stoma site where the surgical incision was made, you can end up getting some stenosis. So all three of those areas are kind of common areas that you might see um, the stenosis happening. All right. So kind of less common ones, you have your tracheal esophageal fistula. This is where you have kind of a direct communication between, or a hole between the trachea and the esophagus. So this happens through incorrect surgical techniques. Like if I make, as I'm slicing, making my incision into the trachea, if I cut too deep, I could go through the back and make that communication surgically into the esophagus. Sepsis is another potential cause. As patients get septic, they're much more susceptible to breakdown, so they can develop these. Malnutrition, tracheal erosion from that cuff or the tube, and then esophageal erosion. So it's coming, the fistula starting on the esophagus side from like an NG tube. So typically, when we're looking at treating any of these types of disorders, that's going to depend on the severity, the length and or circumference of the damage. They might use some laser therapy for small lesions, or they may end up needing to do like a resection where they're cutting the damaged part out and then kind of tying the new loose ends back together. And then they might do like a stage repair where they put kind of stents in to kind of open up those airways, or that damaged part of the airway again. So that tracheoesophageal fistula, again, is that direct communication between the trachea and the esophagus. Um, this can happen a bunch of different ways congenitally. We'll talk about this more when we get to babies and neopeds, but I just wanted to show you that this can be a congenital defect, where babies are just born like this. So in this first TE fistula example, the esophagus isn't fully formed. So my esophagus ends in this kind of like bubble here. So my esophagus stops here and never gets communicated all the way down to the stomach. So all of these need to be repaired with surgery. So the surgeon would go in and attach these and then fix this problem. So with this, there's not that complete communication this way, but because there's no communication between the esophagus and the stomach, these kids are at super high risk of aspiration because anything that's going down the esophagus has nowhere to go and it comes right back up and down into the trachea. So here is an example B where you have that same bubble where the esophagus doesn't go to the stomach, but then it directly attaches right to the trachea. So anything I pour down the esophagus is going to go right into the trachea and then right down into the lungs and cause aspiration. um, Another way, C, is, the trachea, then um, the esophagus isn't attached to the stomach, but the trachea is attached to the stomach. So, I'm going to be risking of aspiration as things go down the esophagus, has nowhere to go, and then it's going to get aspirated back into the trachea. But also, as I breathe or ventilate my patient, a lot of air is going to come and get into the stomach, and I'm going to have a lot of stomach distension because as this air builds up in here, it doesn't have anywhere to go because the air can't come back out the stomach here. Um, so in D, you have it getting attached to the esophagus getting attached to the trachea and then getting attached to the stomach. So again, you've got this, two-way kind of communication for lots of risk for aspiration, lots of risk for stomach distension. And then finally, E is kind of what it looks like if you have that airway trauma causing it, where there's that hole and, food and fluid can go here, it can end up over here. Air can go into the lungs or it's going to end up in the stomach. Remember, everything is going to go path of least resistance. So if it's easier for the air to go into the stomach and fill the stomach up, that's where it's going to want to go. These tracheo innominate artery fistulas. This happens where the trachea erodes that innominate artery. You saw that in the video about tracheomalacia. It kind of showed you where that artery is. If that artery comes directly kind of off of the aorta, so if you create a hole in it, that's gonna result in massive hemorrhages. I have never seen this in the clinical setting, luckily, because only 25% of patients survive this. It's tons and tons of bleeding, not very survivable. So luckily I haven't seen it, but if you do end up having this happen to you or are around when this happens, it's very noticeable. There's a lot of blood. There's going to be a lot of blood coming from the trachea. And you really kind of the only thing you can do while you're waiting for surgical intervention to treat it is you can try hyperinflating the cleft to kind of put pressure on that bleeding site and hopefully dampen the blood flow a little bit through there. But that's kind of the only thing you can do while you're waiting for surgery. So the best way to, treat any type of trauma is actually to prevent the trauma. So tube movement is a big problem or a big reason why we end up with a lot of airway trauma. So we want to minimize the amount of movement that the tube has in the airway. We want to look at trying to keep the patient sedated and comfortable to reduce potential risks of self-extubation. A lot of times there's a lot of people that consider nasal tracheal tubes easier to stabilize. They don't move around as much as oral tracheal tubes, but they also cause increased airway resistance. So I would say we really, clinically, you won't really see a lot of nasal tracheal tubes. We have special swivel adapters that we use with our mechanical ventilators that help take the weight of all of that vent tubing and everything off of the endotracheal tube so that there's less movement that way. You want to make sure you select the correct size. We talked about this in lab last time around, where if I'm picking an airway endotracheal tube that's too small, I'm going to need a lot more cuff pressure to try to keep that airway in place, and that can cause more damage. So I want to make sure I'm using the correct size. If I'm using the wrong size tracheostomy tube, if it's too short or too long, that tip of the tube can then rub on the inside of the airway and cause damage. I want to maintain those cuff pressures between that 20 and 30 centimeters of water to reduce tracheal wall injury. And then I also want to be doing really good trach care. Okay, so we want to reduce the risk of infections on our patients. So you want to make sure that anytime that you're doing any cleaning or suction of the trach tubes, you want to make sure you're doing it sterile. You want to do good trach care routinely, removing those soiled dressings so that you don't have a bunch of old dirty dressings around that fresh surgical site. All of those things are going to help reduce infections in your trach patients. And oral care helps reduce infections, just like oral care helps reduce infections in our mechanically ventilated patients. All right, so airway maintenance. Moving into the readings that are actually official for this chapter, the respiratory therapist must kind of focus on several aspects of airway maintenance when any type of tracheal airway is in place. So there's some critical responsibilities that your book names. So securing and maintaining the tube placement, providing means of patient communication, ensuring adequate humidification, minimizing infection risks, facilitating that secretion clearance that we learned about with suctioning, monitoring and providing appropriate cuff care, and then troubleshooting any airway related problems that come up. So securing the airway, this is again super hard to do in lecture. We'll do that. This is why we're going to do a whole lab on this in week 10. So when you're securing the airway, there's a couple different means by which you can do this. You can use tape. So typically tape is primarily used in surgery, like anesthesia will just tape their endotracheal tubes in place because their patients aren't moving around a lot because they're sedated and they're getting monitored. But we as respiratory therapists rarely will tape our endotracheal tubes. There's a couple scenarios that we're going to talk about in lab that tape is appropriate or probably preferred. A lot of that has to do with COVID and the fact that we've been proning our patients, putting them on their stomachs. So to reduce the risks of pressure ulcers, we've been using tape again for our ICU patients. So that's why I will teach you how to tape endotracheal tubes. Silk tape I know your book talks about silk tape as being adequate, again, in surgery or during, short term. But silk tape is absolute garbage when it comes to oral secretion. So the second your patient starts in with secretions, the silk tape is just going to get lifted right off their face and it's not going to adhere. Cloth tape does a little bit better job holding up to oral secretions, but I would say that the best adhesive remover in the universe is your patient's drools. So in any type of oral secretions, if you get your any of your devices, your tape or your commercial holders wet with secretions, they're not going to stick properly. Commercial securing devices, there's a million different ones out there, a million different manufacturers out there. And then these devices really help with, trying to minimize the amount of skin damage the patient goes through. It's very stable, so it, helps reduce tube movement and they're very secure, so they help reduce self-extubation. So, or unplanned out extubations. Another big thing with securing endotracheal tubes, or even tracheostomy tubes that you need to be aware of is that with endotracheal tubes, you want to rotate where that tube is sitting in the patient's mouth. So I'm going to actually flip to the slide here. If you notice here in this picture here, this tube is in the corner of the patient's mouth. If that tube sits there for a few days, I mean, if you're on the mechanical ventilator, you're not a well patient. So a lot of times these patients are sick, their skin integrity is reduced because of that. So they're much more prone to skin breakdown and alterations than like a normal healthy patient. So, oops. So if I left this endotracheal tube in the corner of this guy's mouth for a couple days, I would definitely start seeing a sore forming in the corner of this patient's mouth. Or even over here with that tape, how that tape is kind of resting in the corner of the patient's mouth on this side, that too would be a site of potential skin breakdown. So I would want to make sure that if I'm using this device that I'm moving that tube or shifting that tube or shifting the placement of this. I think this is tape, but this device is called a comfort, does kind of the same thing. These plastic tubes, if they're sitting in the corner of the patient's mouth, that's going to cause a lot of damage. So you can move those, you need to be moving those around every day. Like once a shift, you should be moving that tube around to prevent that from happening. I'm going to show you the video here on the Anchorfast. How to.
The
This is the most
Anchorfast Guard
common one
Select
we
Oral
use. This is the one we
Endotracheal
have in
Tube
lab.
Fastener
Most of our
provides a
place
convenient means
hospitals
to hold
use
an
these.
oral endotracheal, or ET tube, securely in place without the use of adhesive tape. The oral endotracheal tube fastener allows repositioning of the ET tube in either direction along the track without removal of the device. The fastener secures oral endotracheal tubes ranging in size from 5.0 to 9.0 millimeters inner diameter, and endotracheal tubes with integrated subglottic. The Anchorfast Guard Select Oral Endotracheal Tube Fastener provides a convenient means to hold an oral endotracheal, or ET tube, securely in place without the use of adhesive tape. The oral endotracheal tube fastener allows repositioning of the ET tube in either direction along the track without removal of the device. The fastener secures oral endotracheal tubes ranging in size from 5.0 to 9.0 millimeters inner diameter, and endotracheal tubes with integrated subglottic suction lumen sizes 6.0 to 8.0 millimeters inner diameter. The gliding tube shuttle allows the ET tube to be easily repositioned from side to side while the tube remains secure. The integrated tube protection sleeve helps prevent occlusion without interfering with routine care. Using the Anchorfast Guard Select Oral Endotracheal Tube Fastener. Before applying the device, the patient's skin should be clean, dry, and free of oily residue. Do not use skin gel wipes or other skin preps with the oral endotracheal tube fastener. Remove the product from packaging. Remove the release liners from the two skin barrier pads. Pull back gently on the skin barrier pads so that they are out of the way to prepare for application. Center the device on the patient's upper lip, so the non-absorbent upper lip foam lightly touches the skin. Ensure the ET tube is positioned adjacent to the opening of the tube protection sleeve. Press the two skin barrier pads on the patient's skin and hold in place until they adhere well. This should take approximately 30 seconds. Squeeze the tabs on the sides of the gliding tube shuttle and move the clamp along the track to a location adjacent to the ET tube. Carefully slide the ET tube into the tube protection sleeve. Place the cuff inflation tube within the tube protection sleeve along the bottom and the integrated subglottic suction lumen, if present, within the upper channel of the protection sleeve. Remove the release liner from the ET tube wrap, exposing the adhesive. Before applying the wrap to the ET tube, make sure the ET tube is dry and free of any residue. Position the ET tube under the non-slip grippers. Care should be taken to avoid including the cuff inflation tube and the integrated subglottic suction lumen, if present, within the wrap and/or directly under the non-slip grippers when securing the ET tube. Loop the wrap tightly around only the ET tube and pull the remaining portion of the wrap through the security clamp. Secure the wrap by snapping shut the one-click security clamp. An audible click will be heard. Secure the neck strap by inserting the narrow end of the strap through the plastic loop on the track. Fasten the narrow end of the strap using the hook and loop closure. For greater comfort and security, adjust the straps on either side. Do not over-tighten. Allow 2 fingers width between the strap and the back of the patient's head. To reposition the ET tube, squeeze the gliding tube shuttle tabs on the outer edges and move in either direction along the track. Reposition the ET tube from side to side at least every 2 hours, or more frequently if the patient's condition dictates, to minimize the risk of injury to the skin, lips, and/or oral cavity from unrelieved pressure and shear forces. Release the security clamp holding the wrap in place. Carefully remove the wrap from around the ET tube. Then remove the tube and inflation lumen and the integrated subglottic suction lumen, if present, from the tube protection sleeve. Release the neck strap by unfastening the hook and loop closures. Remove the skin barrier pads by gently peeling them away from the patient's skin. Anchor Fast Guard Select Oral Endotracheal Tube Fastener. For more information, visit hollister.com/anchorfast.
All right. Again, sorry, this is kind of a video heavy lecture just due to the fact that so many of these procedures you kind of have to see to kind of understand. It's hard to talk through them, but this one is just showing an example. There are so many ways to take an endotracheal tube, and I'm not going to get on any soapbox saying this way is the best, this way is the worst, whatever. Really, any way that you can tape, any way your facility has told you to tape the patient that's secure is the way you should be doing it. I do feel like you run more risks of self-extubations or more tube movement if multiple people are taping different ways. Just because tape after a few days, it just looks like kind of a big ball of mess. And if you're not sure which direction the tape was wound, you can spend a lot of time like trying to futz with it and try to peel it back and trying to move it and inadvertently extubate the patient. This is obviously more common in neonates where we were used to tape all of our babies' endotracheal tubes. And then if I taped it one way and Jim taped it a different way, when I came in to move Jim's endotracheal tube, I could easily extubate the patient, not fully understanding how his was taped versus how I usually tape. So here, I'll just play this video as just to give you an example.
This is a demonstration on taping an endotracheal tube. But for Mr. Dunphy, I've got to put some tape around your tube so we can hold it in place. Make sure that you glove up.
See if I can make it a little louder. It's very quiet.
Gloves on. This particular device is already prepackaged, which is convenient. I'm going to open this. Okay, once we open it, looks like so. This has a nice glide, so you can slip it underneath the patient's neck. There is the tape portion, the sticky part, and then the non-sticky. So I want to make sure that the sticky is going to be attached to the patient. So I'm going to take, and it tells you this side up. So I'm going to go underneath. All right, we're going to slide underneath your neck. I'm going to go behind the neck. Then the soft cushion part goes directly behind the neck. So what I do is with my endotracheal tube, I always like to tape the side where the endotracheal tube, the side that it's on. So what I'm going to do now is take off the tape. And then this is already split, so I split it. a little further so I can come here. So I'm going to take the top portion, take off this, hold my endotracheal tube, make sure I have the exact place, and I'm supposed to be 24 at the lip. I am. So I'm going to take this, wrapping around my tube. While I'm wrapping, I do not tape my pilot balloon. Okay, I'm going to wrap this. What I'm going to do at the end, and this makes it real convenient when you're taking it off, I'm going to take the end portion and I'm going to flip it over and I'm going to tab it. Okay, so I'm going to take this, wrap it around. Now this part, I'll take a little bit of that off and I'm going to go over the top of the lip. Okay, Mr. Dunphy has facial hair, so sometimes we can end up having issues, so I may want to get it a little tighter. And I'm going to pull this tape off. Still take here, and I'm going to take the top. So I'm just putting this somewhere that it's staying out of the way. Take this back over the bridge of the lip. Take this around the tape. And it doesn't hurt. I mean, you can actually cut this so it's not so much wrapped around the endotracheal tube. Once again, take the end, tab it, and then come here. Then I take this and I'm going to pull it over the top to add additional stability. So I take here, come over, and then we have a nice tape job.
Right. And this is just an example of what like a tracheostomy tube holder would look like. So tracheostomy tube holders um, typically are kind of this foamy material that have Velcro on each end so that it can fit around the holes on the flange of the trach. And then there is usually an adjuster. So this is actually two pieces of foam, so then I can just, instead of taking it off of here to adjust, I can adjust it back here. These are a little bit nicer than just using trach ties. Trach ties being thin, not very cushioned, that can cause a lot of irritation to the skin around the neck. So after the endotracheal tube is secured, you want to make sure that it's in the proper placement. So proper placement is usually confirmed with a chest x-ray. So the tube tip should be approximately somewhere between 3 to 5 centimeters above the carina in adults, or between the second and fourth tracheal rib. So this is a carina here. I can see that because you can kind of, sometimes if you kind of look at it from far away, you can see just a shadow here of the branching. Right, so that's obviously you see the shadow of the trachea. You see a slight shadow going this way for the branching of the right bronchi, and then the slight shadow over here from the branching of the left bronchi. So right at the point of that branching is the carina. So a lot of the chest x-ray systems even have little measuring tape, so you can measure up from the carina to the tip of the endotracheal tube. That's that radiopaque line, so you can see the tip of the endotracheal tube by following the end of that radiopaque line. And that should be about 3 to 5 centimeters. So the tube position will change with the position of the patient's neck. So this is something that adult therapists aren't real weirdos about, but us NICU therapists, anybody that's ever worked in a NICU, should be absolutely obsessed about this because we have moved way too many tubes, half a centimeter in, half a centimeter out, because of positioning of the patient during the x-ray. So if I flex my neck forward, so if I flex my neck forward where my chin is towards my towards my chest, that is going to move my tip of my endotracheal tube downward towards the carina. Okay. If I extend my head where I'm putting my chin towards the ceiling, that is going to pull the tube toward the larynx. So my tube will be up. And again, in adults, the amount of flexion or extension you're going to create is probably not that much. So that's why they do kind of get a pass and they don't have to worry about this too much. But in babies, this is going to be your worst nightmare if you end up working in an NICU. If you're not at the bedside for every single x-ray, you're going to be moving endotracheal tubes a lot. So the other way that you can confirm placement is with a flexible laryngoscopy or bronchoscopy, where I directly visualize where the end of the endotracheal tube is in the airway.